Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thank you so much for listening to Behind the Knife. This is Patrick Georgioff. I want you to imagine this. It's 2 a.m. and you're rushing a hypotensive trauma patient to the operating room for exploration. Maybe you need to go into the neck, the chest, or the abdomen. Are you prepared for what you might find? Trauma educational resources are extremely limited, and that's why we created the Trauma Surgery Video Atlas. 24 challenging scenarios with high-yield text, beautiful illustrations, and stunning professional-grade video that walks you through the approach and management of devastating injuries in a step-by-step fashion. Check out the link in the show notes for more. There are group discounts available as well. Now, enjoy the episode and dominate the day. Thanks for tuning in. This is Patrick Georgioff with Behind the Knife. Every spring for over 50 years now, the Trauma, Critical Care, and Acute Care Surgery Conference, best known simply as the Mattox Conference, is held in Las Vegas. The conference is unique in that it is entirely focused on practice-changing clinical education, a lot like what we focus on at Behind the Knife. It's also a really good time. Now, one of the favorite features from the conference are the annual debates. Today, we are featuring a showdown between Drs. Ryan Dumas and Bilal Joseph as they battle it out over the use of trauma video review. Now, you can listen on the podcast or watch the debate with the accompanying slides on our website or app. Dominate the day.
Well, good morning and welcome to TCC ACS 2025 debates. I am thrilled to be here with you all this morning. It's great to see so many people stick it out. This is a feature of this meeting annually, and we have some stellar combatants today to go head-to-head on some great topics. With that, just want to run the rules of the road for the debaters. We'll have 10 to 12 minute initial presentations, and that'll be followed by a couple of minutes of rebuttal or question and answers. Either way, if there are questions from the audience, please use the system we've put together to let me know. Once we're done, we'll use a show of hands or sound of applause or some clearly objective measure to declare the winner, okay? So with that, I say we go on ahead and jump right in. This first debate topic is a good one. It's one that I've seen both sides of. Resolved. Video review should be used to improve trauma resuscitation and team performance. Opening our debate today, taking the pro position, will be Ryan Dumas. Ryan is from the Baylor College of Medicine, associate professor of surgery, and a former trainee at my institution, so I am very much looking forward to this. Ryan, the floor is yours.
Thanks, Alex. Thank you, Dr. Mattox and Mary.
Sorry if I just record you, so feedback. Go ahead.
Thank you, Dr. Mattox and Mary, for the invitation to speak. I got to tell you, when I got a call from Dr. Mattox that I had a chance to talk about video review at the Mattox conference, I was beyond thrilled. I spent the last 10 years making video review my mission, and I really just want to get it out there and show you guys what modern trauma performance improvement looks like. So with that, let's get started. These are my disclosures. Now, we're going to hit on a lot of things pretty quickly, all right? But I want to touch on the background. We're going to talk about technical skills in video review. We can now assess procedures we do in the trauma bay using video review. We can watch a thoracotomy, right? We can assess how long it takes. We're going to talk about non-technical skills, huge domain, right? More and more, we're seeing how important non-technical skills are in trauma resuscitation. Then we'll talk about leadership, right? We're quarterbacks in the trauma bay, right? So we'll see what that looks like and how that correlates to our patients' outcomes. And then finally, we'll finish it off with the TVR top 10. So, first, the word about my opponent, Dr. Bilal Joseph, certainly is one of the most accomplished trauma surgeon scientists in our field. And he's going to try to convince you of a lot of things, all right? And honestly, I'm going to let the trauma performance improvement that we can get from video review do all the work. You guys are going to see the impact of video review, okay? But he's going to try to convince you that TVR carries medical legal risk. We have talked to lawyers. We've published about it. Lawyers agree that the benefits of video review far, far outweigh the small medical legal risk of exposure. He's going to tell you it's expensive. Not true. He's going to tell you it's without evidence. He's going to use the words, where's the data? He's going to tell you it's going to be punitive. I'll tell you, we've studied nursing culture, resident culture, trainee culture. It's absolutely very, very well perceived. And he'll also tell you it's just a trend. It's not a trend, guys. We're here talking about it in one of the largest national meetings in trauma. But remember, too, guys, everywhere in modern society, everywhere you go, you're on camera. We're in a casino, right? And so in the city of London, there's one camera for every 13 people, right? One camera for every 13 people. And interestingly, only 3.5% are government controlled. The people we want to know when our Amazon package arrives on our porch on the Ring camera, right? It's part of our society. It's part of the fabric of society now, right? Just last year, the city of Las Vegas implemented 22 brand new cameras just to read license plates. So let's jump into trauma video review, okay? So really, this is not a debate between Bilal and I. This is a debate between EPIC, the electronic medical record, and modern performance improvements. We are high-performing trauma functioning teams, right? We should be just like athletes. There's no way Peyton Manning goes into the Super Bowl and does not watch tape, sees what the team did well, what his opponents are doing, how they could be better, right? This is part of the fiber of sports culture, right? Watching tape. That's Ray Lewis, that's Ed Reed, that's Peyton Manning. They're all watching tape. They're getting better. They're figuring out their weaknesses, how to communicate as a team. Because this is the problem. What does trauma performance improvement in education currently look like? It's the status quo. It's the EMR is fairy tales when it comes to trauma, right? We teach trauma in a vertical fashion, but it doesn't. It happens horizontally. Everything happening at the same time. So trying to recreate a trauma of resuscitation from the EMR is fairy tales. We've all done it. So the devil's in the details, right? That's the thing. And now, using trauma video review, we study leadership, tone, tempo, was it chaotic? How was the time managed? We've heard over and over this week how important it is to get to the next phase of care, right? So now we can measure it, and we can study it, and we can figure out modifiable risk factors to decrease that time. So this is a video. The patient consented to share his video. This is during fellowship, and within the first 30 seconds, watch this patient and the critical mistake that my team makes. There's no audio. This is a transcervical GSW, right? First 30 seconds. What do? Oh, let's lay this patient flat, right? Right? It's the collective sigh. When Kenji Naba showed the videos of the police officers trying to help the patient, it's this collective sigh when we see what we're actually doing in a trauma bay, right? It's really dramatic to watch this play out. I'll tell you, that team never made that mistake again. You'll never find that in an electronic medical record. So, because we've shown this, right? The electronic medical record is woefully inadequate for this, right? So we studied procedural milestones of thoracotomy, and sure enough, with TVR, there's 2 data points were absent that we were not able to capture. With the chart, it's almost all absent, right? So we're taking care of these patients, but we have no idea to tell how we're doing, right? Okay, same thing in pediatric literature, right? In a subgroup, this is pediatric video review. In a subgroup of patients with an ISS of greater than 11, 54 errors in 22 patients were identified, and only 10 of these were identified on the electronic medical record. Again, so I've heard people, oh, what about in-person data collection? So this is the same thing. We looked at this too. We had an in-person data scientist record and watch trauma resuscitations, right? Same thing, totally inaccurate. Right? So now we have a tool to have the most robust data collection, granular data we can get for trauma resuscitation. We can pause, fast forward, rewind, review. And guys, it's not a trend. This is data we published over 10 years ago, not quite 10 years ago from East. It's level 1 and level 2 centers. At the time, 30% of trauma centers were already using video review. I'll tell you, I get at least 1 or 2 emails a month from centers asking for help and advice about how to start a trauma center. OHSU, Duke, UConn, Orlando Health have all started video review centers in the last 6 to 8 months, right? And when video review was first described in 1988 by Hoyt and Shackford, they were using this. This is a cathode ray tube TV. They were wheeling it in with the VCR, dusting off the tapes. Like, we can now do it with this. High definition, HIPAA compliant, audiovisual technology that is not expensive. You can do this for less than $10,000. You can have your team culture, your team dynamics change as you watch your resuscitations. This is just a platform, and you'll see this particular platform, you have a complete 360-degree view of the room, right? You can see what's happening. This one is incorporated with vital signs. So now we talk about terminal bradycardia, we talk about all these things, right? But actually seeing it and seeing as the team gets anchor bias because they're focused on an injury and they're missing the heart rate drop from 140 to 40 is dramatic, right? I've had residents come up and tell me, like, Dr. Umar, that was incredible to watch the heart rate that nobody saw, right? So again, we can do this or we can do this. This is Parkland's Trauma Video Review Multidisciplinary Conference. We sit around just like professional athletes and we watch tape over and over. And I'll tell you, we highlight things that we did well, right? It's not always about finding the mistakes, and it's highlighting the culture, it's changing the culture. It's having a nurse come up to me and be like, hey, Dr. Umar, you really need to watch that video from last night. The team like crushed it, right? Because really measuring quality and team performance in trauma really is two simple things. It's technical skills, and now we can measure those, right? We can say, how fast does it take to decompress the chest? Right? And it's non-technical skills. We have great tools to measure this now. The no-tech scale is widely used in trauma, and we use it a lot to show how teams impact outcomes and how the performance impact outcomes. And only then do we have a full, true measurement of a trauma team's performance, right? And then it's easy. Make benchmarks. Get your team together. Be like, hey, we want to be out of the bay in less than 20 minutes every time. And if we're not, where did we fail? How can we improve? So technical skills. Again, the data is clear, and we've shown, unfortunately, guys, we're not as good as what we do as we think we are, because what we do is really hard. We make really hard decisions with limited information. Time to chest decompression for a chest tube in a hemodynamically abnormal patient is more than 10 minutes. That's the red bar on the right. Right? That's too long. So now we have a benchmark that we can train to, we can simulate to, right? Same thing, time to aorta cross clamp, video reviewed, almost 10 minutes median time to aorta cross clamp in an exsanguinating dying patient. So I only bring this, if you want another great debate between Bilal and I, there's a fantastic podcast out there, but I only talking about IO, and I know IO was talked about a lot last year, but I only bring up this study because 19 centers using video review got together to create a resuscitation database. Now we've grown to 41 centers using trauma video review to study the way we resuscitate and take care of our patients. Non-technical skills, increasingly important, right? So we have shown how EMS timeouts, how well we perform in EMS timeout, correlates to patient outcomes. Also, team performance and technical team performance and how we perform impacts outcomes. For every point degradation in team performance, there was almost a 2-minute delay into the next phase of care. Same thing here, leadership, team decision-making, right, impacts the chances of a ROSC in patients who had ED thoracotomies. So how we function as teams matters, right? Same thing, this is patients who came in alive. The chance of a cardiac arrest in person goes up. Tight team performance is on the right. It goes up pretty predictably at higher team performance, all studied with a camera. Now, the consent process is straightforward. The vast majority of the patient centers using video review use a general consent for treatment. It's well established in the medical literature. We've actually published on it. This is the medical legal review of trauma video review in the entire United States. There's only 2 cases. One of them didn't even involve the video, and the one that did involve the video, the judge did not allow it to be disclosed. But again, video review is so much about culture, guys. If there's one takeaway, is that the more your teams start finding ways to work better together and communicate better, the more you'll change culture. Because ultimately, that's what the lawyers said. They said that your chance of decreasing errors increases much, much more than the slight medical legal risk of exposure. And finally, perception is universally great. We've done before and after studies of programs that have implemented programs, and it is well perceived by everybody who's under the lens. So let's finish off with the top 10. Video review really offers an unparalleled way to study team dynamics during resuscitation, right? This is absolutely critical. We can study now the way we do technical procedures, the way we communicate. The medical legal risk is overstated. TVR data is much, much more accurate than an electronic medical record, is much, much more accurate than prospective data, right? And guys, it's here to stay. The technology is only going to get better, right? And we can incorporate it into all our aspects: performance improvement, educational conferences, research. And I'll tell you, it's not going anywhere, because now we're moving it to the operating room, right? We're studying critical events in the operating room and how the teams perform. And we're identifying errors for opportunity for improvement and changing the way we communicate and talk to one another. And finally, we've heard all week about AI. These are some collaborators at Stanford. And now we're overlaying AI to help us. This is such an incredible data source that the next challenge is how to use all that data and how to impact our patients' outcomes. Thank you.
Thank you, Dr. Dumas. Taking the con position is a surgeon and scientist that needs no introduction, a dear friend. Please welcome from the University of Arizona, Dr. Bilal Joseph.
Good morning. This is your first Mattox meeting, isn't it?
Yes.
Yeah, you mentioned, I've just changed my talk. You mentioned that it's being presented here. I just want you to know things come here sometimes to live on and sometimes to die. History doesn't favor those being watched. It actually favors those doing the watching. So before we turn the trauma bay into Baywatch, let's talk about what we're really talking about here. I think it's important. Nothing to disclose. Dr. Mattox did ask me to be nicer this year. I'm arguing the more difficult side of the position. There's no doubt about it. You are all under surveillance, as he mentioned, without consent, which is his way of doing things. History teaches us that those who record things often end up in trouble. Oh, sorry, that was my other talk. I apologize for that. Dr. Dumas and I go way back. He's right. We had a great podcast on Behind the Knife, and this email he sent me was almost 2 years ago, and he always tries to manipulate you and the whole narrative. And so I just put that email up there. But last year when I presented on IOs and we killed IOs for resuscitation at this meeting, I sent him the video and I put judgment because Dr. Mattox gave his review, and he's like, and then he tries to mock Dr. Mattox and says, saphenous vein cut down in 15 seconds, eh? Think I can convince Dr. Mattox to install IO kits in every bay when I move to Ben Taub in September? And out of respect to you and your privacy, I didn't go down the rest of the talk there. I stopped there. Let's just be clear. So he is an expert. There's no doubt about it. He's been writing about this for over 10 years. He's got over 19 publications. I've never written. I don't know a lot about this. I had to learn as I went on. He has podcasts and videos. And so there's no doubt that we're here in his world. His generation is the generation of selfies and pictures. And every time you eat something, you got to take a picture of it to make sure it tastes good. And so I understand where you come from. It's really cool. And this is a bad trauma bay. You may wonder why it's bad. And this is a good trauma bay. And this is even a better trauma bay. But the truth is, you can watch that video 100 times. It's not going to stop bleeding. It's not going to save a patient's life. And, Dr. Cotton has mentioned this a couple times. Big Brother is watching you. And he mentioned the litigation risk. He said, I was going to say it's a highly litigated area. We'll talk a little about this with his own paper. 9% of trauma centers experience medical legal issues. Only 3% reported an actual medical legal case that actually went to court. But like everything, one case is enough to kind of shut down everything. 30% of centers don't consent their patients. Around 50% of centers consent within a broad consent form. He showed that first video of the cutting the patient's clothes and the patient's face was exposed. Does your consent allow that? But if you watched his video 3 videos later, when he had the medical professionals there, they all had white boxes over them. And that's a mistake, I will tell you. I just picked up on that while he was presenting. But did we get consent to put the patient's face in front of all of you? I don't think so. And so Dr. Dumas' definition of HIPAA, helping invading privacy on admission agreements. And then if you're going to consent patients to the video, do they have a right to it? Good question. Another paper here. I'm going to be very objective with data here because I think data is super important. Determine patients' perceptions of audio-video recording, not in trauma, elective patients who were going to be recorded. What they were concerned about. Privacy and data breach. Tampering of recordings. Surgeons doing things differently because they're being watched. Focus on the recordings rather than the patients. And then, did they have the rights to their videos? They want to learn about their procedures. And what about medical legal things? Why don't we give them their recordings? Why do we record and not give them their recordings? So what about the impact on us as surgeons and providers? How does that work? And the truth is, TBR comes with a few things that have been documented. The Hawthorne effect, anxiety, time consumption, and we'll talk a little bit more about that. What is the Hawthorne effect? When you're on camera, you act differently. We have 7 trauma bays in Tucson. One of them has a camera in it. Works sometimes it doesn't. We don't really use it. We don't do video review at our center. I could promise you, when you walk in that room, you are different than any other trauma bay. And that's a real effect. And so that's a real question to bring forward. And are we seeing reality or just the response to being watched? I think that's important. The feedback of the patient laying flat, you could have told someone to change that instead of having a video review to tell you that. And then here's another paper, 38 ED and trauma staff members in Toronto, Canada. And how did they feel after being video recorded? Provoked anxiety, general discomfort, fear. It's real things. And then the residents. We heard a whole session on how our resident and trainees are changing the way they are. Fear of judgment discourages taking initiative. TVR is teaching tool may intimidate rather than empower. This is real people, real life answers to questions. This is not my opinion. Half of what he was telling you was his opinion. He was extrapolating that by doing these things, we can change outcomes. That's not the truth. And then eroding trust and creating a culture of blame between team members. That's a real thing. Again, that's what when you sit in a room with your ED colleagues and your trauma colleagues and the video is being played, that's a real hard thing to kind of talk about. And are we fostering psychological safety or breeding fear and hesitation? And this is how he does his resident orientations. There's a camera here and a camera there and a camera everywhere. The TVR process really requires a lot of time. It's not an easy process. 40% of evaluators note that the video review process is time consuming. Is it taking us away from watching the patient and doing patient care when we're watching videos? A study found that the majority of centers review less than 50% of the total resuscitations. We record all these videos and more than half of them, and this study was done by Dr. Damas. What are we doing with all these videos if we're not watching them? I mean, if video review is so good, why don't we watch all our videos? I mean, this is his data. It's not my data. Really, why are we doing this? What do we do with the unreviewed videos? Another question. I mean, it is cool. It feels great, but I don't know. What about data breach? Is that a reality? We've presented at this conference multiple times. Every 7 seconds, the dark web is coming in and taking our data. States are affected by healthcare data breaches. Average cost, $9.2 million. And Ryan, so you can understand that's about 6,000 cameras if you want to do the math to kind of understand what that would cost you. But it's a real thing. People are coming after our data all the time as a terror weapon, as taking down hospital systems. It's a real thing. We have to be careful with this. And then does it really work? This is the most important question to everything. There's the hindsight, the Monday morning quarterback hindsight bias, the tendency to see events more predictable and preventable after they occurred. So you go in there and you're like, oh, look, we should have done this. We should have cut the glue. We should have sat him up. Was that going to change the actual outcome of that patient? How much you take away from that video review? Have you ever done that study? How about unfair judgment? Decisions made in real time are judged with the advantage of knowing the outcome. We know what happens to that patient when we're telling people, you should have done this, you should have done this, we should have gone this, or hey, great job doing the chest tube. But are you going to really change the chest tube insertion that went into the liver by watching a video? I don't know. About overestimating predictability. I love his energy. Like, it's so positive. I'm just trying to bring him back a little bit to Raboa and IOs. Like, let's just be real here. I'm not saying we shouldn't do it at all, but we got to be careful. And are we really seeing reality or judging the past with an unfair, clear image of what's happening? And here's another study. 25 patients were included in the study. They did video review and then they did EMR review. So they looked at the EMR, they looked at the video. TVR missed more variables than EMR. They were able to get 1,200 variables from looking at the EMRs, 700 watching videos. And most of the medications there and ability to assess came in the TVR. So there's ways to review. I'm not against it. I'm just saying that you got to be careful what we're really taking. Another data, that's another thing, unfortunately, Dr. Damas, he's written 19 papers and he only reads his papers. If he would read other people's papers, he would see areas he could improve. 140 participants, physicians and nurses. They did video-assisted oral debriefing or just oral debriefing afterwards on BLS and AED scenarios. They pre-tested, post-tested the intervention. No difference when they used the video and not. Just talking about it was enough. Here's another paper. 284 patients with cardiac arrest were brought in. They did video review and then put these teams back out there to change the outcome of the patients. The word outcome is the most important word here. What did they see? They did see a better improvement of ROSC in the video review. Survival to hospital admission on discharge did not change. So what are we really fixing by doing this? The biggest flaws really are, every hospital has a different regulation. Some let you do it, some don't. Some want the tapes. Some people give it to the patients. Some people don't. Should we review every video? Why are you recording patients if you're not going to do it? And if it's so good, why don't we review all of them? His paper said 50% of the time they don't even look at the videos. Should we record every patient? That's the other thing. And so I really think, how long should we keep the videos? 30 days, a year, 6 months? Will they be litigated? I promise you the lawyers can get those videos if they want them. And no study has ever measured outcomes after video review. There's studies that have measured other things. In trauma, he's written 19 papers. Why haven't you written one on an outcome difference? That you actually improve patient care? Because it doesn't. So world's greatest unsolved mysteries, Area 51, the Loch Ness Monster, and the camera in the trauma bay. I think the take-home points are video review increases your risk of litigations, his own data. Don't just blow that off. It's real. Patient privacy is a real risk. And this consent is, I'm going to use a word, bullshit. 80% of patients don't know they're being recorded. And they have this, our consent form in Banner Health, I think is 27 pages. And the third line is you may be able to use video to put in your chart and all this stuff. But a complete video, people are signing this without knowing that you're going to be bringing it to a national forum and showing their face, for example. And I just picked up on that today. I think it's important, man. You got to be careful with this. Compromises surgeon psychological safety. It's not that easy. It does impact us. Zero clinical trials or studies on the clinical outcomes. And then my hindsight bias was I already knew I was going to win this debate. I want to thank Dr. Dumas for this debate. Thank you very much.
It's always a pleasure to watch the rookie debaters walk into the lion's mouth here, Ryan. All right, we're in the interest of getting us back on time, which we will from the previous session. I'd like each debater to have no longer than a 1-minute rebuttal. We'll turn it to you, Ryan.
I feel like I walked into a bit of a trap here.
No, I think Bilal makes some excellent points, but honestly, I want to hit on the consent. HIPAA protects the use of videographic data, right? It's clear. We can use videos, right? That video that I showed, I have explicit consent from the patient on a signed consent form. So videos that are used internally, we keep in for PI, QI processes. The vast majority of centers delete the videos in 30 days. The lawyers that we have spoken to over and over across multiple institutions always say the same thing. It decreases your legal risk exposure by improving quality of care, metrics, culture. When we get better and identify our weaknesses, we get better as teams. That's how that works. And then one of the things, honestly, like these videos will save lives. What we do is high impact, low frequency, right? So that's why we don't need to watch all the videos. That's true. We need to watch the ones that impact, the timing is so critical. Thoracotomy, crikes, airway management. That's the ones we save and look for in the video reconference and then delete. That's the video that matters. So we're not watching all the videos. That's true.
Ryan,
And
that flashing red light down there, that's the one that means your time's up.
There was a time we watched the patients, and now he's talking about videos of thoracotomies. These are sick, dying patients. Are you really going to change anything in that moment? In sports, they always say, sports, we watch videos. Well, if you win or lose the game, you get the video. Why don't patients get their videos then? Why are we so protective? And I would just say, Ryan, I want you to take this and continue to push it forward. Just read other data out there to help you. I really think it's important. But look, there may be some uses for it, but at the end of the day, just be careful. Don't get on this train just because it's cool. It is one. I know he mentioned that wasn't a real thing, but it is a real thing. I don't think it's changed anything yet. We've been doing this for a long, long time, and video reviews have been around for a long, long time. It's just we got another champion for a little bit, and we'll see how long this one goes. Thank you very much.
All right. It's time to cast judgment on this debate. If we could bring the house lights up, thank you. All those who believe that Dr. Dumas carried the day with the pro position, please raise your hand. Ooh. All right. All those who believe Dr. Joseph carried the day today, please raise your hand. I hate to say it, Ryan. I think the old dog's got it.
I love you guys.
The old dog's got it. All right. A round of applause for the debaters. Thank you very much.
Good job, boys. Good job, boys. Yeah, great job. Great job.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.